fifth episode of the Nervous. Hello, and welcome to our fifth episode of the Nervous Breakdown podcast. We have a very special guest here today, Dr. Nicholas Sarujas. If you would please like to introduce yourself.
Hello, everyone. This is Dr. Nicholas Rujas, an epilepsy specialist, who will talk today about seizures, epilepsy, movement disorders, functional neurological disorders, and a range of other neurological conditions. Nice to meet
Okay.
everyone.
Oh yeah.
And I will be essentially the primary video content creator in this. And the topic we will explore today is the topic of epilepsy and functional neurological disorders in general. Now, what is the first case on today's agenda?
So first, let's break down a little bit what is epilepsy and how we get this repetitive or hypersynchronous firing and some of the mechanisms and the pathophysiology behind this vast array of presentations of this condition.
So, epilepsy in general is a condition that can actually affect anyone. There is a almost 5% lifetime risk of anyone having seizures throughout their lifetime, and that risk could fluctuate or vary from 1 up to 5% depending on the age group and exposures of an individual.
So first, let's kick it off with what actually is epilepsy.
Well, epilepsy is hypersynchronous activity or excessive neuronal firing in regions of the brain which causes recurrent seizures. Now, could you go explore the clinical implications of epilepsy and the kind of patients you deal with on a day-to-day basis?
So, epilepsy presents with a range of clinical manifestations. If you think of the brain as able to sense information from the environment and give motor outputs, epilepsy can range from a range of sensory, perceptual, experiential symptoms to a whole range of motor manifestations.
Okay, so could you paint a little bit of a picture of how epilepsy interplays with either genetic factors? Let's look at maybe some of the sodium channels, potassium channels, and then maybe a little bit about how it interacts with patients and the environment that they live in or grown up in, things like depression, anxiety, and all these mood disorders, as you say.
So, first of all, everyone has a lifetime risk of having a seizure of about 5%, which could vary from 1 up to 5% depending on their age, possibly their genetics, as well the environment they grow in, exposures to different toxins or chemicals, as well as lifestyle, including sleep or sleep deprivation, emotional distress or dysregulation, and so forth. As you can see, epilepsy has to do a lot with the brain development itself, as well as with the genetic predisposition and the environmental exposures. Now, in principle, the distribution of epilepsy across the entire lifespan is bimodal. And by that I mean that there's a high frequency of or an intensity of seizures in those who are less than 25 years of age. And there's a second mode or peak of epilepsy, which are in the case of those who are over 50 years of age. Why do you think we have this particular life distribution in the modal expression of epilepsy?
Well, first of all, I would think these are the times in which the brain is really seeing the big changes. At young ages, you have a lot of plasticity and really forming your neuronal networks. But towards the end of your life, you're seeing a lot more degeneration, and these networks are breaking down, neurodegenerative disorders ensue, and it's kind of the times in which the nervous system is really moldable and has the capability of change. And it's this capability of change that really allows for loops and networks to be reorganized and start this excessive firing pattern. Um, so, you yourself, in your own practice, what have you really seen to be the biggest determinant of your patients presenting with epilepsy? And how do you really go about dealing with this and really getting to into the holistic care of the patient and really trying to find the root cause of their seizures.
So, first of all, I think one of the most common provoking factors of epilepsy is poor sleep hygiene and sleep deprivation. I would consider this as the number one. And the second, probably most important factor is probably emotional distress or dysregulation. Now, in addition to these very common factors which can exist in everyone's lifetime, other important risk factors could be different environmental exposures, exposures to toxins and poisons, and I have to mention here the most common poison in every country these days, at least in the Western world, is alcohol and different recreational or illicit drugs. And these are actually what would affect the younger age population.
I think that is very insightful.
I kind of just wanted to get a little bit of the feel about what you meant with emotional dysregulation. How does this manifestation of, let's say, mood come about in triggering epilepsy? What is it about dysfunction in your emotional, your limbic networks, for example, that brings about the capability of excessive neuronal firing?
So, our understanding of epilepsy these days is that there is an excessive or hypersynchronous firing of a small population of cells, of neurons in the brain. However, this is a very common theme, something that happens very commonly throughout the entire brain, every moment of our lives. Different populations of neurons can fire excessively at any time. Do all these excessive neuronal firings translate into seizures and epilepsy? Probably not. The majority actually of excessive neuronal firings is kept under control by the system. Under what conditions do you think a local population that goes firing excessively will actually spread, propagate sufficiently enough to give an output of a clinical manifestation of a seizure, to output seizures? In order for something like that to happen, larger scale brain networks have to be engaged in the process. So even if small populations of neurons fire excessively, these will have to engage or entrain large scale brain networks for seizures to manifest. Now, you may ask yourself, what are the large scale networks in the brain? Can you describe to me some of these large scale networks?
Yes. So the parallel comes in between the doors, the default mode network and the central executive network. These are your two states of mind, really, and in between these is the salience network, kind of a mediator between these two states. Um, so these are both limbocortical networks, and they span throughout the whole brain, involving areas of the prefrontal cortex, involving subcortical structures, and also a lot of parietal and sensory influence.
Can I stop you there for a
Yeah,
second?
please.
So, if you look at the default mode network, the default mode network comprises extensive limbocortical networks, which involve not only the hippocampus um, and the parahippocampal gyrus and the rhinal cortex, but also the amygdala, the anterior cingulate cortex, the mesial prefrontal cortex, and the orbitofrontal cortex. This is a quite extensive, I would say, network that involves particularly the mesial structures of the brain and spans across the temporal, parietal, and frontal lobes, and together is interconnected with deeper nuclei structures such as the thalamus and the basal ganglia. So the mesial side of the brain, I would say, is dominated by the so-called extensive limbocortical networks. On the other hand, the dorsal side of the brain which involves particularly the dorsolateral prefrontal cortex, as well as the parietal cortex. The dorsolateral side of it is actually part of the so-called central executive network or frontoparietal network. So this is dominantly on the external side of the brain. Now, these two networks mediate different activities. The default mode network is particularly focused on self-referential thoughts and processes that have to do with learning, memories, and behavioral regulation, while the external parts of the brain, the central executive or from the parietal network, is mostly involved in goal-directed external activities where attention and goal-directed tasks need to be carried out. Now, the salience network, which is in some ways a part of the mesial part of the structure, mesiocortical networks, is basically composed of structures like the anterior cingulate gyrus, the anterior insula, the amygdala, and the posterior insula as well, and is basically a network that determines the salience of different stimuli and allocation of resources, whether they're going to be more towards the executive from the parietal network or a default towards the default mode network.
Yes, so thank you very much for that. I hear you explored this a little bit in the Mind and Music talk presentation you gave at the Hungarian List Institute. And it's subject now for a chapter that you're writing in a book. Could you please elaborate more on this
Yes,
and your work?
we took this idea that seizures, for example, and movement disorders, they actually take advantage of large-scale networks so that excessive or hypersynchronous firing of neurons actually finds its way to entrain large-scale networks and result in the motor or sensory motor output of what patients experience as seizures. So this same idea, we explored it in the Franz Liszt Institute lecture on the neuroscience of music and arts, where we explore different ways how the brain is using those large-scale networks to engage in different processes during music listening or production, during voice and singing, and to find out how could music actually modulate these large-scale networks, sometimes to our benefit and sometimes protecting us from having seizures or improving different movement disorders.
So, I think a very important thing we should cover is how do seizures occur in the body? How through these different networks and interactions across neurons, across junctions, across the neuromuscular junction, how this actually leads to a seizure. And what really is a seizure?
Okay, so a seizure is, as we said, it's a local burst of neuronal firing, which is excessive or hypersynchronous. That would not necessarily translate into a seizure that is clinically manifested. To have a clinical manifestation of a seizure, that excessive neuronal firing needs to spread sufficiently throughout the cortex of the brain. It needs to engage larger scale networks and literally seize particular key or large scale cortical areas.
During a seizure, what you have is something known as rhythmic firing, where certain parts of your body, this could be of the brain, yes, but also when you're looking at the symptoms themselves, e.g., spasms or tremors, you have like a rhythmic firing in these certain areas where action potentials are fired continuously and continuously, and you kind of lose the integrity of individual action potentials being fired. Now, something we really need to understand is how this rhythmic firing occurs, and we will get into later on how we can try and modulate certain channels on the membrane and how we can try and stop this rhythmic firing, disrupt this continuous signal, and ensure that we can even treat patients and make them seizure free.
Right.
Yeah, I guess what you're trying to go with here is how the seizure manifests not only at the large scale networks, but how it goes all the way down into the single neuron. So
Yeah.
could you please elaborate on some of the different types of seizures, some of the different symptoms you see, whether it's a focal or a generalized seizure, whether it's tonic or clonic, the motor output of this. So please elaborate how we see these large scale networks transforming into seizures and how the individual neuron level is also susceptible to this excessive rhythmic firing.
First of all, I would like to challenge this misconception that generalized seizures or epilepsies are actually seizures that start at the same time from every part of the brain, or that they engage and seize the entire brain or cortex. There's nothing less true than this. The reason being that generalized, literally in clinical term, means that it can start from different parts of the brain, but not from the entire brain at the same time. Generalized does not mean that it necessarily engages or seizes the entire cortex or the entire brain.
But can it have a systemic effect on multiple regions of the brain and the whole body?
Yes, generalized seizures usually tend to spread very rapidly, involve possibly large parts of the brain, but not the entire brain, and they would most likely affect frontotemporal networks, which are crucial for uh, awareness and consciousness. Therefore, generalized seizures and epilepsies would result in loss of consciousness, and since they affect mostly frontotemporal networks and all the motor manifestations come from the frontal lobe, they will have particularly motor output and motor manifestations. On the other hand, focal epilepsies are not necessarily localized in a small part of the brain. A lot of the focal epilepsies could be quite extensive, involving the entire hemisphere or even bilateral hemispheres. The only difference from the generalized seizures is that they would consistently start from the same region of the brain. So they would have the same initial semiology, as we say, because they start from the same region of the brain, and they would spread in preferential propagation networks, and they could even secondarily generalize. That means they could spread into much wider areas of bilateral both hemisphere uh, uh, brain networks.
Okay, so how do you see this in a clinical setting? What is it that you see when a patient presents to you with any of these types of seizures
Well,
or
when the
epilepsy?
patient first presents with any kind of seizures, what I would really like to know is the number, the frequency of the events, and how they're distributed in time. Are there particular times of the day that they occur? Is there any particular pattern that emerges over the weeks or the months? Because often we can identify provoking factors that could be associated with them. For example, if seizures emerge usually from sleep or in the early morning hours, that makes us suspect that there is an involvement of underlying involvement of brain rhythms through sleep awake cycle. And in that case, sleep hygiene could be very important to prevent seizure manifestation. On the other hand, if there is a pattern of seizures that emerges, for example, after someone consumes alcohol or uses recreational or illicit drugs, then certainly there is an element of toxins and poisoning of the brain, which needs to be addressed by removal of the precipitating substances.
Yeah, I find it fascinating how much you really need to gain an understanding of a patient's life, their lifestyle, to see how their seizures and what is onsetting their seizures or any triggers they may have. So you really must have a really deep and must build really good rapport and a really deep patient-doctor relationship. So how is it that you're able to kind of identify the triggers? You've seen what their lifestyle entails, whether they take alcohol, you understand their sleep schedules, things like that. What is it that you do? How do you go about treating the patient? What things do you need to consider? And what is it through your practice over the years that you've identified to be most effective to really reduce seizure rate? I think you mentioned that 80% of seizures are treatable. Is that right? Or
Yes, yes. Patients can be rendered up to 80%, sometimes even more, seizure free in the longer run, or certainly be rendered seizure free for long periods of time. That is something that may occur naturally in the natural progression of the disease, but it may be also facilitated by drugs and antiepileptic medications or anti-seizure medications, as we like to call them these days, and of course with different lifestyle modification. But you're right, as the first thing I would like to know after the intensity and the patterns of the seizure, the frequency and the patterns of the seizures, would be the initial semiology. I think the initial semiology of the seizure is the most important determinant of what kind of um, seizures and epilepsy type a patient may have, and also for addressing the underlying epileptogenic networks.
A very important question I'd like to also know is that would you say that your primary mode of treatment or your most effective mode of treatment is, or a most effective improvement of someone's health is lifestyle changes, or actually trying to treat them with certain antiepileptic drugs and medications?
Well, let's be honest about it. There's no antiepileptic medication on board that could match and undo what an aberrant lifestyle can bring on to someone's life. No matter how much you try to treat a patient, if someone is sleep deprived, is exposed to alcohol, is exposed to recreational drugs, is under emotional distress, or you expose with a photosensitive epilepsy, you expose him to flashing lights. No matter how much or how many antiepileptic medication you use, you may not be able really to control the manifestation of seizures in these circumstances. That tells us already that lifestyle modification is of utmost importance, is paramount for treating patients with seizures and bringing their epilepsies under control. Now, what the medication does is adds an extra, let's say, layer of protection where it raises the seizure threshold. So you may not be able to reach the threshold and manifest the seizure, but you may still be having breakthrough seizures as long as you can reach that threshold by simply being exposed to all these provoking factors.
First, we should understand the idea of depolarization. They bind to ligands on the receptor, the drugs acting as binding molecules that have a higher affinity to the inactivated state of the voltage gated sodium channel. So they bind to the inactivated state when the gate is closed, and they create certain hydrogen bonds and hydrophobic interactions.
here, some of the mechanism action of these drugs is they will cross the phospholipid membrane and they will enter from the inside and bind to hydrophobic pockets within the core of the pore of the sodium voltage gated channel. They use an acid-based system where it's the cationic form that is eliciting the drug binding and this blocking of the pore. However, to pass through the membrane, it's really a hydrophobic residue they'll have to pass through. So the HA form rather than the A minus form.
Thank you for watching the Nervous Breakdown podcast. This was the 5th episode with our special, esteemed guest, Dr. Nicholas Saruhas.
Yeah, thank you for tuning in. I think this was a really comprehensive view where we got a grasp of a range of different perspectives and approaches you use to view epilepsy. You have your emotional aspect, you have your pharmacological aspect, you have your physiological aspect, looking at it from the single neuron, and it's really about integrating all of these to really be able to help a patient in their own lifestyle, in their own daily lives, being able to cut down on their triggers and maximize their percentage of becoming seizure free, and trying to steer away from just using medication, which seems like quite a rudimentary approach. First, you must try your conservative measures and then progress to your medical approaches. So I think the way you look at it with your patient-centered approach, which you have exemplified through your practice, and especially through the rapport and the connections you build with your patient, I think it's a truly unique and great way for you to practice medicine and deliver the best patient-centered care.
Thank you for your invitation to the podcast. We just barely touched upon today some basics of epilepsy, and we saw the implications of these interventions in seizure control. And I hope your guests fare well.
Thank
Yeah.
you.
Please stay tuned for some of our other episodes where we won't only be bringing to you uh, epilepsy, but we'll also be looking at other different movement disorders and mood disorders as well. So please stay tuned for that. If you want to check out our other podcast episodes where we also take dives into pharmacological, immunological,
Immuno
and
coagulation.
that's and physiological and pathophysiological processes, please stay tuned for that, and we will have more guests coming on the channel.